tracheostomy stoma to heal prior to feeding the patient. And we do this because it's readily apparent to us that the presence of a tracheostomy will contribute to difficulty swallowing and particularly aspiration, and result in pneumonia for the patient if fed in this type of situation. We know there's a lot of other patients who also have tracheostomies who can't get rid of their tracheostomies. And these patients oftentimes are found in rehabilitation hospitals throughout the country where they've had some form of neurologic insult or trauma or some other form of condition that results in the need for a tracheostomy that has then contributed, if you will, to difficulty swallowing. Well, you know, we noticed some time ago that it seemed that patients who had their tracheostomies removed were able to swallow better, and we postulated that maybe a Passy-Muir valve would do something similar, in that allowing the patient to develop subglottic air pressure may indeed help the patient swallow. The Passy-Muir valve would enable the patient to swallow by enhancing subglottic air pressure. So we actually looked at this in a prospective manner with 11 patients several years ago and found that indeed what we postulated was correct, and that was that patients with tracheostomies who aspirated, that the presence of a Passy-Muir valve allowed these patients to swallow with either a reduction or perhaps even in some cases elimination of the aspiration. Interestingly, when I spoke to the speech and language pathologists and that I happened to discuss this with, many of them said to me, oh, we've known that for a long time, that when the patient has a Passy-Muir valve, they have less secretions, there's less difficulty with oral secretions, and they seem to swallow better. It's not only the fact that these patients have decreased secretions because of evaporation or what other etiology, but also that the presence of the valve enables these patients to swallow more efficiently and with less aspiration. And as a result, over the past year or so at the University of Pittsburgh and the VA Medical Center in Pittsburgh, we've used the Passy-Muir valve extensively to assist patients with swallowing disorders. One such patient is Dan Gilmore, who hopefully you're having an opportunity to meet in an interview today. And there are several other patients that in our facilities and in the rehab hospitals in our community who have been dramatically assisted in their swallowing by the presence of a Passy-Muir valve.
So that's some of my experience, and hopefully if you're in a situation where you might find yourself now where I was a few years ago or somewhere in the middle there, you can see it certainly helps to make friends, and we have more than anecdotal information now, which I'm really excited about. Some other things that came out from our research was that people seem to sense and double swallow and know that material was there and during the same study, and that was an interesting finding. Another thing is I viewed these videotapes, I would turn and I'd say, did that look faster to you? And remember, I'm on and off, same person, same time. How could that be? And I remember one of the texts saying it was. So I started to time the pharyngeal kinematics, the movement of the pharynx separate from the bolus. I just want to see what these muscles are doing. In patients that aspirate, I found that the swallow was 200 milliseconds slower. These are aspirating patients when the system was open as opposed to when it was closed. And what's interesting about that is that's a long time. And that is enough time actually for the cortex to make an attempt to process the information, and that could be one of the compensatory mechanisms that some people are able to use. That's way too long for a reflex. What I'm doing now is I'm studying patients that are long-term valve users, and I'm studying, and they're non-aspirating, and I'm doing valve on and valve off, and I don't see that difference. This data is not fully analyzed. I don't know if it'll stand the test of statistics in terms of a difference, but there's either less of a difference or no difference. So this larynx is healthier, possibly, than the other larynx, and it does provide some information possibly about how we compensate. The other thing is you'll see there's less residue. That, I think, is key to the possibility that bolus transit is improved when you're able to get enough air into the system to pressurize it and send it through. Another thing, if you've read some of Dr. McConnell's work, he does a lot of manometry, there's a pressure drop when the bolus enters the esophagus. I don't know if anyone's familiar with that, but he called it a hypopharyngeal suction pump, saying the negative pressure, and there are those in the history of swallowing that thought there was a sucking, this drop. It's possible that now that we know this is an air-filled chamber going by into a smaller lumen, that what we're seeing is a Bernoulli effect, which is really new information. I don't know, but I surely would love to find out. And the fact that aspiration is reduced or eliminated, and as Dr. Eibling said, secretions. Reduced secretions could be also effective improved swallowing function for all the reasons I've given you. So anyway, I think that I tend to repeat many of the things during my lecture, but I want you to integrate them all, that this isn't magic. You can't, it's not magic and it's not a fluke. There are physiologic things going on. We just don't understand them yet. But we do know that it's not just coordination and sensation, but if you deflate the cuff, you're going to also promote improved laryngeal elevation, because you have to deflate the cuff to place a speaking valve. So inadvertently, you're doing other things. You're getting airflow through. You're taking care of this impingement on the cricopharyngeus. And so you're doing more than establishing improved airflow. You also are affecting airway closure, as Sasaki's work, and it has been replicated, but in animal models has shown you do have a better closure of the larynx. In the old days, if you remember, any aspiration was no good. We didn't allow for any, but we're lightening up on that, because there's a difference between aspiration that's proximal to the larynx and distal. And if someone, say head and neck, has proximal aspiration, if they can cough and clear, we're going to allow it these days because they have a clearing mechanism. Certainly, especially in head and neck, if you can get a valve on that doesn't leak and restore these pressures, you're going to have a better cough, and this patient will have a better chance of continuing to eat by mouth. Restoration of smell has been shown to improve appetite and general well-being. And you know, when you have a cold, and I want you to think about that too, it's hard to eat when you're stuffed up and the system isn't right. Not only just not having taste, but I think that's interesting that even our own systems can be disrupted. So as a therapist and therapists working together and healthcare professionals working together, we need to certainly assess the impact of the tracheostomy on swallowing function, taking into account all the things that the cuff does and the tethering and the procedure, and then going on to think about subglottic pressures, airflow. And keep this in mind during your swallowing evaluation. I think we're at a point now where perhaps the eval isn't done if you don't try to restore the subglottic pressures and all of the airflow through the larynx. And I'm not a big advocate of the blue dye test unless it's combined with fees. And I think that we've moved on. We used to have to demonstrate gross aspiration to be able to study patients and go on. But anyway, should you be doing blue dye tests and combining them with fees, which I think is the proper way, I think we now have good enough reason to also add placing a valve, placing the Passy-Muir valve, and comparing pharyngeal residue, some of the timing factors that you can see with fees if you can't go to fluoroscopy. If you can go to fluoroscopy, I recommend that the evaluation isn't over until you have restored all the pressures and tried the valve for all the reasons I keep reiterating, that possibly your patient may benefit. And in the lab today, you'll see a gross observation of a patient that would not have eaten had they not gone on to have the system closed up again. And as I'd mentioned, fees is a quantitative procedure. Same with compensatory swallowing techniques. If you can't stop the aspiration, at least you can maximize the function of the system. There's no evidence for this. I'm the first to admit it, but we're working on it, and possibly, if only during a swallowing therapy session, you can, if that's the only time you can restore airflow through the larynx, possibly there is a maintenance factor, and possibly we can maintain function and avoid this prolonged problem that occurs even after the trach has been removed. So I do everything I can to keep this system, and some of the data that I am gathering now is showing that that possibly could be going on. You have a better chance of your patient accomplishing swallowing exercises. After a thorough evaluation, you usually know, do you need more laryngeal elevation? Do you need more base of tongue retraction? They have a better chance with a system that's maximized of reaching these goals, and certainly during trial feedings. So our ultimate goal is to improve swallowing and reduce aspiration, and I really think that one of the keys in the tracheostomy patients, and it's not magic, we're doing many things by placing a speaking valve, and the Passy-Muir in particular, in restoring the system and helping us reach our ultimate goals. Thank you very much. Questions? Thanks. Can I take a few questions? The question is, when I'm doing a video fluoroscopy, for example, do I always use a Passy-Muir valve, or do I also cap the trach? Generally, I haven't had patients that you're able to cap the trach. So if my patients have been sicker as a rule or earlier in their recovery, and I was forced to look for an alternative method because capping and decannulation weren't on the list at the time. If you have a patient that can be capped, then certainly you're doing the same thing. And the same goes if you can get the trach out. And sometimes that's what I work for. Get the thing out, and here's how you can get closer to it. And as they mentioned, they use the Passy-Muir valve for weaning, which would be a step, and then go on to capping. And finally, certainly the best is to get rid of it. Yeah? Are you regularly fluoroscopy? Okay, she asks if I'm regularly taking ICU patients to video fluoroscopy. You can't do that every place, and you can't do it with everyone. And those that you can't, I would recommend combining fees with the blue dye, not just blue dye alone, because the problem there is if they do aspirate, you don't know why. And chances are you've given them a sentence they're not going to be able to eat, they're not going to let you go on. So I think more information is better. So, but even if you're doing that, see if you can get the situation right, because you can, even in a facility where they're not doing this, you can pull up articles now and say, look, this isn't magic, this is what the system does. Air may play a role, and certainly seems to be playing 3 roles. The subglottic pressures triggering mechanoreceptors, the pneumatic component, and possibly providing a physical barrier. Okay, she asks how long is prolonged intubation, and the study that I'm citing, and I know Michael DeVita, he works in critical care medicine, and he considered prolonged intubation 2 weeks. So 2 weeks and thereafter. She asks about reimbursement issues and how I have valves on hand. How can you? Generally, and I learned this from my pediatrician, before I do my evaluation, I write the words, the patient will benefit from restoration of airflow, air pressures via Passy-Muir speaking valve, please order. So I have it to try, to play with, to work toward whatever I'm doing. But the word benefit seems to be very helpful. The patient will benefit, so that's what I've done. Does that answer? Okay, thanks again.
I'd like to talk about the aspects of the Passy-Muir valve and swallowing. You did hear a lecture in regards to this, and I'd like to talk a little bit further about some of the information that you heard. The tracheostomy tube itself can create some swallowing problems in patients that you generally would not expect there to be a swallowing problem. Why is this? Well, first of all, it's because you have a trach tube that is going to tether the larynx, so the larynx is not able to elevate as well as it would if the trach tube was not there. Here's the larynx, and here's the trach tube. Again, when you're trying to swallow, you're going to have some tethering effect. In addition, the airflow that usually goes from the lungs up through the vocal cords and out the nose and mouth is redirected. Instead, it's going in and out the trach tube. So you lose sensation in the laryngeal pharyngeal area, and as a result, you will find patients might pool secretions or food or liquid because they do not feel, they do not sense that that is there because there's no airflow in that area. Another problem that the trach tube can create is the fact that you've got a loss of subglottic air pressure. Since you're breathing in and out through the tube, you do not have subglottic pressure forming underneath the vocal cords because you're losing that air out the trach tube. As a result, your swallow can be impaired. Now, if you have a patient with a cuffed tracheostomy tube and the cuff is inflated, which is what I will do right now, all of the effects that the tracheostomy tube has on swallowing are going to be intensified because of the fact that now there is no leakage of air around the trach tube that might be able to get up to the upper airway. You have all the air going in and out through the trach tube. So sensation in the laryngeal and pharyngeal area is going to be reduced significantly. In addition, with the cuff inflated, you have now probably created more of a tether effect. As the patient tries to elevate the larynx while they're swallowing, they have more tether or more anchoring going on with that cuff inflated. In addition, you are not going to have that subglottic air pressure that we talked about that's so important in having a good swallow. This also affects cough. A patient with a trach tube is going to have a weakened cough because all of the air is escaping beneath the vocal fold level. They're not able to create that positive subglottic air pressure they need for a good cough. One other aspect of a tracheostomy tube with a cuff is the potential for the cuff to be overinflated. And let me demonstrate what happens with an overinflated cuff. As you can see, there is impingement of the tracheoesophageal wall, the wall that is the common wall between the trachea and the esophagus. Now, what happens with a patient who's trying to swallow is they might have been able to get a bolus of food through the esophagus until they reach this point where there's a stricture, and they might end up having a reflux problem and aspirate after the swallow. An overinflated cuff has many other complications, such as having irritation to the tracheal wall, breakdown, and sometimes even a tracheoesophageal fistula. So having that cuff inflated is not generally helpful in terms of swallowing. Now, you might find that some patients have a cuff inflated because they are seen as a chronic aspirator, and that means that they are not able to swallow or manage their secretions, and those secretions fall down into the airway and eventually can cause complications such as aspiration pneumonia. So they have a cuff inflated to at least slow down the process of those secretions getting down into the lower airways. The cuff does not prevent aspiration from occurring because there should not be a complete seal against the tracheal wall and the cuff, because again you're going to have the possibility of complications, breakdown of tissue. Therefore, you're going to have some leakage of the secretions or the food on top of the cuff down into the airway, and again that could promote aspiration pneumonia. With your chronic aspirators, you might think, well, we do need to keep that cuff inflated, but I'd like to encourage you to think about being able to use the Passy-Muir valve to possibly be able to perform some exercises to improve the swallowing. Let's talk a little bit about how the Passy-Muir valve can facilitate swallow in a tracheostomized patient. First, making sure that the cuff is completely deflated. We'll then place the Passy-Muir valve on. Okay. Now remember, you now have redirected the airflow when you put the speaking valve on. The patient inhales through the trach tube, but they're exhaling now through the upper airway, the normal route. Okay? The air is going around the trach tube and around the deflated cuff and up through the vocal cords. Why does this affect swallowing? Well, first of all, what you've done is you've restored airflow through the larynx and the pharyngeal areas. That means you're going to have the potential for increased sensation, which is very important for patients to, if they sense that there's any pooling, they can swallow again, they might be able to cough or to clear their throat, to clear that material. In addition, you've also, because you've restored that airflow and you don't have an open system anymore, you are able to restore the subglottic air pressure that is so necessary for swallowing. You are breathing through, exhaling through that upper airway. You've restored a more normal closed system, and that subglottic pressure is restored. In addition, since with using the Passy-Muir valve, you cannot have an inflated cuff, you need to have a deflated cuff. You no longer have that anchoring effect, at least that the cuff would add to the system. So in a way, you've at least minimized that as much as possible. What I'd like to do now is to show you a videotape of a patient that's mechanically ventilated and was assessed for swallowing using the modified barium swallow study. That is a study that's done in radiology with a radiologist and generally a dysphagia specialist, many times a speech pathologist or an occupational therapist. And they take a look at swallowing. It's a dynamic study, and they can examine if the patient's aspirating and why, and be able to possibly do some maneuvers during that study that will help ameliorate that problem. What you're going to see, as I said, is a mechanically ventilated patient who had a history of COPD, and he was a chronic aspirator. The clinician will be narrating her own modified barium swallow study and tell you what it is that you're seeing. I do want to tell you, before you watch this video, the therapist will mention that she does the study 3 days apart, and you might think, well, that might give you a chance for spontaneous recovery, and it's not the valve at all. Well, this is a chronic patient who had many months of swallowing problems, so that is probably not the case in this video that you watch. So with that, we will show you the video.
The following is a series of swallows by a tracheostomized patient. He was mechanically ventilated at the time of the study with the Passy-Muir valve not on and the tracheostomy cuff fully inflated. The first swallow is a pureed bolus. The patient has a small amount of residue in the vallecula and the piriform sinuses. Since the cuff is inflated and he has no active airflow through his oropharynx, he has reduced pharyngeal sensation and demonstrates no awareness of this residue. He does not attempt a dry swallow spontaneously. The second bolus is a thick liquid. Laryngeal excursion is reduced. The patient has larger and more diffuse residue in the pharynx with this bolus. With this large amount of residue, he does spontaneously attempt a dry swallow, but is unsuccessful in clearing the residue. The residue begins to penetrate into his laryngeal vestibule. When the patient is cued to tuck his chin and dry swallow, some of the pharyngeal residue is cleared. However, the penetrated material remains. The third bolus is again a thick liquid, but the patient is cued to chin tuck during the swallow. Again, he demonstrates reduced laryngeal movement. Pharyngeal residue is noted, but less than when a chin tuck was not used. Penetrated material from the previous bolus has now been aspirated past the vocal folds. No cough is triggered. With the cuff inflated, He can spontaneously cough, but has very limited ability to clear this material from his upper airway until or unless the bolus leaks around the cuff and can be expelled through the tracheostomy tube. The last bolus is a thin liquid. Aspiration is noted during the swallow, again with no spontaneous cough response. This patient is reassessed 3 days later, still mechanically ventilated, but with his cuff fully deflated and the Passy-Muir valve on. The biggest changes noted are 1. Improved pharyngeal sensation due to airflow through the oropharynx, and 2. Improved laryngeal movement, which results in reduced pharyngeal residue, especially in the piriform sinuses. The first bolus is thick liquid. He has difficulty getting started. His movements are somewhat discoordinated and weak. There is pharyngeal residue after the first swallow, but with improved sensation in his oropharynx, he senses this residue and dry swallows spontaneously. He is successful in clearing the piriform sinuses, with a small amount of residue remaining in the vallecula. This is most commonly due to reduced tongue movement and is not improved or worsened with the use of the Passy-Muir valve. Thin liquid is the next bolus given. There is no residue in the piriforms and none of the diffuse pharyngeal residue seen earlier with the Passy-Muir valve off. No aspiration occurs. A chin tuck is helpful in clearing vallecular residue. Now we try a thin liquid using a chin tuck right from the start. Less vallecular residue is observed and still no penetration or aspiration. Next is a pureed bolus. Again, improved laryngeal movement and pharyngeal clearing are noted. No penetration or aspiration. In order to further assess the safety of his swallowing with the Passy-Muir valve on, we eliminate the chin tuck and try a large, thin liquid bolus. Even with the large bolus, he is successful in clearing his pharynx without any aspiration. Finally, the last bolus is a solid. His laryngeal movement and pharyngeal clearing are consistent with his function with pureed and liquids. Since these evals were completed, this patient has been successfully maintained on a general diet using the Passy-Muir valve and chin tuck during all meals.
As you can see, there was a significant difference with that patient. He was in fact able to begin eating orally again using the Passy-Muir valve. Why does that Passy-Muir valve make such a difference with that patient? Just reviewing a little bit is because you've restored the subglottic pressure, you restored sensation because airflow is now going through the upper airway, and you've also reduced that tethering effect of the cuff on the larynx, on the laryngeal movement. I'd like to throw out a few questions to you right now. Let's say that you were doing that modified barium swallow study with this particular patient, and instead of deflating the cuff and putting the valve on, you just deflated the cuff. Okay. What do you think you might see if you had just deflated the cuff? Would it be better than having the cuff inflated? Okay, well, the answer to that would be yes. It would be better, and why would that be? That's because you've restored airflow through the upper airway, so at least you're going to have a little more sensation. Most of the air is still going to escape out the trach tube, but you will have a little bit of air going up through the upper airway, so you might feasibly have improved the swallow a little bit. You also have reduced the tethering of the cuff on the larynx because you've deflated that cuff. What about positive subglottic air pressure? Has that been restored by just deflating the cuff? Okay, the answer to that is no, Okay, you have not restored the subglottic pressure because you still have an open system. The patient's still inhaling and exhaling or receiving the breath from the ventilator through the trach tube. Let's take that one step further, and let's say that you have the cuff deflated, but then you put the Passy-Muir valve on. What is it that you have added in that particular case? Okay. It's actually the fact that with the Passy-Muir valve on, you have restored the subglottic air pressure. And that way the patient has a better cough, and also those pressures are very important in helping to have a more efficient and faster and safer swallow. It is important for you to know that although the valve can improve swallowing in many, many patients, the extent of improvement is going to vary with each patient. As you know, many times etiologies of the patient will indicate that they're going to have a swallowing problem regardless of the presence of a trach. So the valve can be used as a very important tool to help minimize the effect that the trach tube is having on the patient's swallow, and can in fact be a very dramatic effect that can allow them to begin to be oral eaters again. It's important for you to assess the patients for use of the Passy-Muir valve with their swallowing.
We at Passy-Muir wish to thank you for viewing this videotape.